thanks so much for joining us for this webinar. I'm Neeraj Prashar. So since this is the first webinar which is being conducted, sir, with you, so I'll take this opportunity to welcome you and all the other audience which has joined us, all the relevant doctors, and I would like to welcome them on behalf of Hetero Healthcare. To start with, sir, I would introduce myself also. I'm Neeraj Prashar, the sales manager from Healion, seniors division of Hetero Healthcare Limited. So first of all, thank you for joining us today for this webinar, and to speak on the subject and to discuss on benefits of Rivastigmine, particularly transdermal patches over Donepezil oral tablets as well as Rivastigmine oral tablets. So before we start, with the presentation which you are going to share with us, I would initially like to introduce Hetero Healthcare, which a lot of us know that Hetero Healthcare has been an organization which is one of the biggest R&D wings, which has been providing 360-degree solutions, across the related industry and the segment. Doctors, Hetero has, more than 25 years of excellence in multiple therapies and is present in more than 126 and more countries across the globe. Also talking about Hetero, sir, Hetero has more than 200 products across, various different therapeutic segments where we have been operating, which have been more than 15 now. To name a few, it has been like HIV, AIDS, oncology, cardiovascular, and neurology. Where in HIV or antiretroviral drugs, we are having, more than 40% global market share. Not only this, since we have been very strong with R&D and innovation, so, I very proudly share with you that Hetero also has the distinction of bringing 4 biosimilar products into the market. Also, not only this, sir, we also have, state-of-the-art, manufacturing facilities, providing, the best of the standards and which have been, in terms of count, more than 36 plus. And not only this, sir, Hetero is committed towards pioneering in quality as well as innovation in the segment we are into. So with this, a little brief about Hetero Healthcare. Now, I would like to take this opportunity to introduce and welcome our esteemed Dr. Shreyansh Dwivedi, who is with us and will be taking us through the presentation. Dr. Shreyansh has been a senior consulting psychiatrist at Ravi Neuropsychiatry Center in Varanasi since last more than a decade and has established that clinic in around 2013. Talking about Dr. Shreyansh, he did his MBBS, MD, and DPM from the institute, which was CIP Ranchi. Dr. Shreyansh also has been working as an ex-senior resident at Safdarjung Hospital, New Delhi. Then Dr. Shreyansh also has been working at senior Sahab Ambedkar or Baba Sahab Ambedkar Hospital, which was at again New Delhi, and also at IBHAS, New Delhi. So with this, it's a little brief about the organization, this little brief about, the subject, we are going to discuss and have your valuable insights. I would now, sir, request you to kindly take us this forum and, to share and discuss, more on the subject. Once, sir, you take us through your presentation, then I would also request you to kindly address the queries, which would be coming from the other esteemed doctors who have been joining us for this webinar. So with this, sir, I would now request you to kindly take us through with your presentation, and over to you, sir.
Okay, thank you, Mr. Parasar, and thank you all the team Hetero and especially the team Hetriva for giving me the opportunity to present you this presentation. So let us start with our main presentation. So let's talk about dementia first. Like it's a emerging topic, and general life expectancy of like entire world is growing, and so does the life expectancy of India is also. So we will be having more and more old people nowadays, and the geriatric medicine and the problem associated with geriatric age group will be more pertinent to our clinical practice. So let's talk about dementia, which is a common geriatric problem, which we see like encounter almost every day. So talking about dementia, it's a neurodegenerative and progressive disorder. So there is a degeneration of neurons and the brain matter, all, and also it is a progressive disorder or deteriorating disorder. So day by day or year by year, the patient will get even worse. So dementia is a brain disorder that slowly destroys memory and thinking skills, and eventually the ability to carry out the simplest tasks. People with dementia also experience changes in behavior and personality. So there are many other aspects of dementia, like we have to look into cellular pathological level, and there's some changes in the histological level, and we can see some changes in the macro level also, based on these two changes. So let's talk about the risk factors of dementia. For Alzheimer's disease, it's obviously the age, since it's a geriatric problem, hypertension, increased cholesterol levels, coronary artery diseases, and diabetes. It's the main risk factors. Other risk factors are like genetics. Some people are more vulnerable for dementia as compared to others. Smoking, alcohol use can precipitate dementia early in the age. Plasma homocysteine level is very significant. We see dementia very early in Down syndrome, and if you have mild cognitive impairment after a certain age, maybe like 50, 55, then you are more prone to have dementia later on. So there are some morphological and histopathological changes. So they are regarding Alzheimer's type dementia. So there is a deposition of plus and neurofibrillary changes. And vascular type, there is a cognitive impairment associated with decreased blood flow. And there is a Lewy body dementia, the deposition of alpha-synuclein protein. And there are many other type of dementias like frontotemporal dementia, Huntington's disease dementia associated with Parkinsonism also. So let us talk about dementia or Alzheimer's disease, which is the most common, what we see every day, or the mixed type of dementia associated with Alzheimer's as well as the vascular type. So we can generally see there's mild variant of dementia, like people usually misplace items and they ask similar questions repeatedly. Moderate, like increasing confusion and disorientation. Problems with speech or languages, and severe, like difficulty in eating and swallowing. A significant problem with short and long-term memory. In severe dementia, people like the old person or the person usually have very poor quality of life because they don't know where to defecate, how to dress and undress, and they have very poor self-care, very poor hygiene. And at times, when they leave home, it's very difficult for them to trace their way back to home. So, dementia, it's a very disabling issue. I think there was a movie also, like Black or something. I don't know, don't remember it. Where like Amitabh Bachchan was having Alzheimer's type of dementia, along with the movie was with Rani Mukherjee. And looking at the treatment options, dementia. So there are few US FDA approved molecules like Donepezil, Rivastigmine, galantamine, and these are cholinesterase inhibitors, and other as N-methyl D-aspartate receptor antagonist like memantine, and we can use combination of both the medicines. So the dose is mentioned like donepezil, we can use 5 to 10 milligram, and in severe cases we can use 10 to 23 milligram. Rivastigmine and galantamine all are used in mild to moderate cases, and we usually use a combination in severe patients. So let's talk about the molecule in our focus, rivastigmine. So its mechanism of action, it's a choline esterase inhibitor used in the treatment of all stages of Alzheimer's disease, administered orally or via transdermal patch to reduce the prevalence of side effects. It inhibits both acetylcholine esterase and butyrylcholine esterase, but it is more selective for the G1 isoform. of acetylcholine is stressed that predominates in certain areas of brain. It has a small molecule and highly lipid soluble, thus easily enters the brain. So that's very important. Rivastigmine pharmacokinetics, it's 60 to 72% biologically available, 40% binded to protein. It is primarily metabolized in liver with elimination half-life of 2 hours, and mostly it is excreted 97% in urine. So the common side effects are nausea, vomiting, decreased appetite, and weight loss. So their drug interaction is very few. No interaction with digoxin, diazepam, warfarin, or fluoxetine, and should not be used with other cholinesterase drug, and should not be used with metoclopramide. There is an increased risk of EPS. If used with cardioselective beta blocker, additional bradykinetic effect can occur, resulting in syncope. We should not use with cardioselective beta blockers. Obviously, we have to use in some specific population, but regarding other population, pregnancy, I don't think it's very relevant, but it is not recommended. And it is not excreted in breast milk, and no, pediatric use, we don't find too much dementia in pediatric patients. So I don't think that's very relevant here. Regarding contraindication, if there's any history of hypersensitivity or other medication containing carbamide derivatives, so we should not use in those patients. Somebody has previously taken anti-cholinesterase drugs, experienced a cholinergic crisis, so we should not use these in those patients also. And if some patient has history of allergic dermatitis with a patch, so that should be avoided. Talking about the rivastigmine transdermal patch, so molecule is very small, hydrophilic, lipophilic molecule. So it is suitable for transdermal patch. So it has a lag time of half to 1 hour. Cmax is attained after 8 hours. There is a slow decline after reaching Cmax, and low fluctuating trough and peak level, approximately 60 to 80%. Effective if used in upper back, chest, or upper arm. So there are certain benefits of the transdermal patches. So it can be given once daily. We can see the half-life is very less, 2 hours. So we can use transdermal pens once daily. It can be used in patient having difficulty in taking oral drug also. It causes low pill burden, can be applied independently of food intake. And also if the patch is there, it gives a very good visual reminder, like I have taken medicine or the medicine is already sticking on my body. So regarding the few scientific studies, SWAP study design, it was randomized, double-blinded, open-label, parallel group study. It was done for 5 weeks on 20 feet in extension phase. Total number of patients was 261. Evaluation, the main aim was to evaluate the tolerability and safety of switching from oral Donepezil to rivastigmine transdermal patch. So majority of the patient receiving the Donepezil tablets can be safely switched to rivastigmine transdermal patch without significant deterioration in cognition, behavior, and global functional with well tolerability. So an ideal study was 24-week in this study duration. It was double-blind, randomized, placebo-controlled, multi-centric study comparing the efficacy and tolerability of the 6 milligram BD rivastigmine capsule versus 9.5 milligram per hour and 17.4 milligram per 24-hour rivastigmine patches with placebo, and the total number of patients were 1,195. So conclusion was favorable skin tolerability for rivastigmine transdermal patches provide assurance related to the benefits of rivastigmine patch therapy in the patient with Alzheimer's disease. Optima study, so it was comparing efficacy, safety, and tolerability of higher dose of rivastigmine patch. So it was 72 96-week multicentric study with total number of patients 1,979. Conclusion was it demonstrated higher dose efficacy of the 13.3 milligram per 24-hour rivastigmine patch on functional outcomes without compromising safety and tolerability. Action study, prospective randomized double-blind double dummy multicentric trial for duration of 24 weeks and number of patients for 1,014. Comparing the efficacy, safety, and tolerability of 13.3 milligram per 24 hour versus 24 milligram per 24 hour is Rivastigmine patch. Conclusion was higher dose efficacy of the 13.3 milligram per 24 hour Rivastigmine patch exhibited superior efficacy compared to the 4.6 milligram patch without any significant increase in adverse effect. It suggests higher dose of patch has a favorable benefit to risk profile in severe Alzheimer's disease. Summing the findings, oral acetylcholine is inhibitor leads to GI adverse effect, particularly nausea and vomiting, preventing patients from achieving and maintaining optimal therapeutic doses. Rivastigmine transdermal patch show reduced side effects, thus allowing patient to reach target dose more easily and to stay on the treatment for a longer duration. A transdermal patch could be optimal way of delivering rivastigmine in the pharmacological Alzheimer's disease. So, regarding the Hetriva USP, it is simple. Once daily administration can be used in the patient having difficulty in taking oral drugs. It reduces the pill burden and can be used independently of food intake. It's parental use, so it bypasses first one metabolism, thus increases bioavailability, improves adherence due to less side effects, encourages caregiver, eases anxiety associated with medication management, provide visual reminder and assurance of the treatment. So it is available in 9, 18, 27 milligram per 24-hour patch. It usually 9 milligram releases 4.6 milligram in 24 hours, 18 milligram releases 9.5 milligram in 24 hours, and 27 milligram releases 13.3 milligram in 24 hours. And there's MRP of 15 patches are like mentioned. You can note that. And its indication is mild to moderate Alzheimer's disease and target specialties, psychiatry, geriatric, and neurology. So its indication for the treatment of the patient with mild to moderate severe dementia of Alzheimer's type and dementia associated with Parkinson's disease for the treatment of patients with all stages of dementia of the Alzheimer's type. So we have to initiate with 9 milligram patch. After 4 weeks, we can titrate up to 80 milligram patch for maintenance. And after 4 weeks, again, we can again hike the dose to 27 milligram patch. So this is the rate MRP of the single patch. So the area of the patch is also mentioned 5 centimeters square, 10 centimeter, and 15 centimeters square with the MRP 65, 75, 85. So what if somebody has stopped using the transdermal patch? So regarding interruption and discontinuation treatment. So treatment should be temporarily interrupted if GI adverse effects are observed. Until these adverse effects resolve, patch treatment can be resumed at the same dose if the treatment is not interrupted for more than 3 days. Otherwise, treatment should be reinitiated with 9 milligram. So if patient misses the dose for more than 3 days, initiate with 9 milligram. If adverse effect persists on reinitiation of therapy, the dose should be temporarily reduced to 9 milligram. Renal impairment, so there is no dose adjustment is necessary for the patient with renal impairment. Hetriva, shifting from oral to patch. So a patient who is on dose of less than 3 milligram BID oral rivastigmine can be switched to 9 milligram transdermal patch. A patient who is on the dose of 3 to 6 milligram BID, like 6 to 12 milligram per day, oral rivastigmine may be directly switched to 18 milligram patch. Thank you.
So thanks for the presentation. I would request Giridhar, if you can share with us any queries from the audience on the subject.
No, sir. From queries, there are no questions.
So one of the queries which I have just got, sir, and I would like to, request if you could enlighten us on that. So, sir, if, patient is on oral Donepezil, for, more than 6 to 7 months, and the patient has to be transferred to this transdermal patch of Hetriva, which is rivastigmine. What is the dosage transformation you would suggest? So can you hear
Personally,
me?
I have, yeah. Personally,
Yeah, sir.
transdermal patch, shifting to transdermal patch is not a problem in most of the patients. And like I have seen, if somebody is tolerating the oral regimen, it usually tolerates the transdermal patch also. And the evidence, the incidence of adverse effect is usually a few uh, for transdermal patch as compared to the oral medications. Regarding the that I have mentioned it in a slide, like if somebody is taking less than 3 milligram BID dose, so we can start with the transdermal dose of 9 milligram, the patch of 9 milligram, so which gives approximately 4.6 milligram per day. Or if
Correct, sir.
the patient is using 3 to 6, more than 3 milligram up to 6 milligram BID dose, so we can straight away start with 18 milligram patch, which gives around more than 9 milligram, 9 point, I think, 5 or 6 milligram per day. So we can definitely that, and it's very smooth and very convenient. What I usually
So,
recommend after taking bath, just clean the surface and apply the patch over there. Do not apply on the same places. Just keep on rotating over the back and make a visual memory of that where I have applied and make a follow pattern. And after a
right,
certain
sir.
time, after a few days, maybe like 10, 15 days, I think same area can be repeated. And
True, sir.
people usually respond very well. Alzheimer's disease is a type of disease which, like even after treatment, few patient will show improvement. Few patient means like uh, not very significant. Very few patients can show improvement. Same is true with Rivastigmine, but I think few patients with the severe disease have shown improvement in their symptoms. They have better uh, uh, daily functioning also. But since it's a neurodegenerative disorder, so we should use in the patient as soon as patient is getting diagnosed.
Correct, sir. Sir, another very general query which I get to get from the doctors is since Donepezil is working on acetylcholine esterase, but with rivastigmine it is like both acetylcholine and butyrylcholine esterase. So if a doctor the patient is already on oral Donepezil, would it be fine then to on immediate basis transfer the patient or put the patient onto rivastigmine patch?
Immediately, like there are certain studies. Like for me, I have started the patient with patch directly. Like uh, patient was drug naive, like no anti-Alzheimer's medication, and the patient was diagnosed as Alzheimer's. I have started the patient directly. And regarding to example, I have also uh, changed it. But usually I ask them to give a gap. Like you should like give a couple of days gap. Like once you run with Donepezil, just stop Donepezil and wait for a couple of days. Then you start with the patch.
Right.
So that's my
Okay.
recommendation because both of the same class of medication should not be used simultaneously. So just to give a brief drug wash. That's all.
Correct, sir. Correct, correct. Sir, another query which has just come in is in terms of so this was from donepezil to rivastigmine, but if the patient is already on rivastigmine oral formulation and has to be put on patches, so do you suggest
Immediate.
uh, immediate
Immediate can be
usage
done.
of
Yeah, immediate can be done.
wonderful, sir, wonderful. Another, sir, like, query which is generally also coming to us. Do you think, sir, these days, these patients, who undergo a trauma, wherein, their certain cognitive impairment is also there. So do you think, sir, there could be any use of rivastigmine or donepezil into, such patients who can help, regaining those cognitive conditions.
See, the thing is like the mechanism of cognitive impairment or the dementia in the patient with trauma is different from the mechanism what we experience in the patient with Alzheimer's disease. So there are many other medications which are being recommended in the patient with trauma. We can use them also. Like I have presented a similar thing, like a patient with similar presentation. of cognitive impairment and dementia in the patient with neurotrauma. So in these patients, usually acetylcholinesterase inhibitors are kept as a reserve medication. They are not used in the first line. So it is usually kept
Correct.
as a reserve medication. Not we shouldn't use them on the first hand.
Correct, sir. Correct. Right, sir. Wonderful. And since, sir, you shared about Rivastigmine, this is a very feedback frequently which we are getting is because of the oral formulation, Donepezil, or for that case, even Rivastigmine oral formulation also. There's a lot of GI disturbance, which happens because it is mostly with the geriatric patients. So,
Mhm.
do you think, sir, patch helps, as you shared also in your presentation, but in your clinical experience, if I can ask you, sir, how the response of the patient in terms of, any patient earlier on oral formulation with the GI disturbance, but once you would have put on patch. So, how's the experience, sir, which has been shared by the patient in terms of GI disturbances?
First, there is a decreased incidence of GI disturbance molecule-wise also. If you use Donepezil and if you shift to Rivastigmine, so the incidence of GI disturbance is usually less in Rivastigmine as compared to Donepezil. And even few adverse effects are there when we use in the transdermal. So using transdermal patch is usually a win-win situation in the patient. So we can definitely use that.
Correct, sir. Right, sir. So, sir, these were like little few queries, sir, which had been coming to us. So with, sir, there would be a lot many, sir, which would be coming as post session also, which will try to bring it across to you. And the inputs shared by you, sir, we then try to take it across to the other doctors, across, where we have been meeting, because these insights always do help. So, sir, now, sir, on behalf of Hetero Healthcare and the audience, I would like to, thank you and extend my sincere gratitude for sparing your time from your always occupied schedule, which I know has been there, and to speak on the topic and, enlightening us on use of Rivastigmine patches. And it's in comparison to the oral formulation of Donepezil and Rivastigmine both. Sir, I must say that your presentation was not only informative but also inspiring and transformative. The insights, I think, sir, which you have provided were very insonating with the audience also. Also, sir, along with that, because this is the first webinar we had done with you, so I would definitely like to mention that you had a very unique perspective and engaging style, on the subject which we had been selected to today.
Thank
I'm
you.
deeply, sir, appreciative of the time and the efforts which you have put in customizing your presentation on the subject for the audience. I'm definitely sure that the thoughts and the experience shared today by you, will be definitely be applied in various ways by the audience, which are the other relevant doctors with us, for managing patients with dementia, and considering Rivastigmine transdermal patches as one of the option. So, sir, please accept this small token of thanks from us, and I really do extend my gratitude. I do, sir, definitely look forward for the other opportunities to collaborate with you for future on the same subject and the other relevant subject with your specialty. So with this, sir, I would like to thank you once again for sparing your time for this wonderful presentation and enlightening us, and hope to, sir, collaborate with you for many such programs in times to come.
Thank you, Mr. Parasa, for inviting me.
Thank you, sir.
Thank you, sir. Thank you.
Thank
Thanks a
you.
lot,
Thank
sir.
you.
Thanks for giving your time,
Thanks.
sir. Thank you.
Thanks.
Thanks.